Good afternoon and good evening, and thank you for joining us here for the Center for Global Health's seminar series, examining effective global health partnerships. We're joined for this session with Dr. Corrado Concedda, who happens to be the Botswana Upenn Partnership Director. He's joined by his colleague, um, and they'll be discussing their partnership in Botswana and the lessons learned from Botswana. And with that, I'll turn it over to Dr. Concedda to introduce his colleague and explain a little bit more
Yeah, well,
about his
thank you so
presentation.
much. And again, I'm not alone here. I'm here with Dr. Malebongo, who is the advisor for primary healthcare at the Ministry of Health and Wellness. And it's just a privilege to have her here. Thank you, Alejo, for organizing this presentation, and to the attendees. So without further ado, I'll share the screen and we'll go over the slides. There's quite a few of them. We feel like we had a lot that we wanted to say. So we'll try to go through them quickly, and then we'll try to be done in 45 minutes, and then we'll gladly take questions from the attendees. Okay, so yeah, the title is Transformational Partnerships in Global Health, Lessons from Botswana. And you have all these like logos down here, not by chance, right? Because really so much of what the Botswana Upenn Partnership does is collaborating with other organizations and institutions, both in Philadelphia and in Botswana, including the Ministry of Health and Wellness, of which Dr. Malebongo is a representative and a leader. So I can't talk about BUP without giving credit to countless leaders, champions that came long before me, started it, supported it over the years. Of course, front and center, Professor Harvey Friedman. It goes without saying. And BUP has been in Botswana for 20 years, and there's like really a ton to celebrate. We were initially invited by ACHAP, that's the African Comprehensive AIDS Partnership, the Bill and Melinda Gates Foundation, the Merck Foundation, the government of Botswana, to support Botswana's response to the HIV pandemic in 2001. We consolidated our working relationship with the Ministry of Health and University of Botswana. That's what UB stands for, in 2004. And since then, there have been literally hundreds of partnerships, collaborations, professional exchanges that occurred between Penn, CHOP, and Botswana faculty, trainees, health professionals because of BUP. In terms of program and initiatives, again, we started out with HIV. We launched a program in 2003 that scaled up access to high quality and comprehensive preventative and curative services for tens of thousands of HIV patients. Since then, we've launched a telemedicine program, cervical cancer screening program, the Medical Education Partnership Initiative. This list is by no means comprehensive. Okay, these are really like the highlights of the highlights. We secured approximately $32 million in grants over the past 20 years, probably more than that, and published at least 200 articles on peer-reviewed journals. This figure is actually a few years old, so I suspect we're much higher than that. We trained a ton of people, both in the US and in Botswana. And the cool thing is that US and Botswana students were trained together. And again, across all levels of education, from undergraduate to doctorate to master to postgraduate education. We've also had Botswana students go to Penn for clinical observerships, and then of course we have Botswana students complete a master in epidemiology at Penn, both in HIV and in trauma and injury. I think that's really one of the programs that we're the proudest of. And then of course health service delivery, because both the faculty and the trainees that came from Philadelphia have engaged in clinical care, health service delivery activities across a broad range of specialties and subspecialties in many of Botswana's public hospitals and clinics, starting with Princess Marina Hospital. Now, the thing is that Botswana now is not the Botswana 20 years ago, right? So many things have changed. Again, I mentioned before, we started with the HIV pandemic that was really devastating the whole sub-Saharan African region and having a huge impact in Botswana. There was the money from the Global Fund and the President Emergency Fund for AIDS Release. The Millennium Development Goals were the North Star of international development, and Botswana needed support in starting people on ARVs, actually diagnosing people, starting people on ARVs who had HIV. Since then, of course, as people with HIV live longer and healthier lives because of treatment, there has been the rise of NCDs, and now, of course, which is non-communicable diseases, and now, of course, the COVID-19 pandemic, but also the country is moving in a different direction. It has taken ownership of most of the HIV program. They have this wonderful vision for 2036. They want to become a high-income country. And of course, health is a big component of that vision. And the Sustainable Development Goals are the North Star of international development. So how does BUP fit in, right? Like, how can we evolve to adapt to the new circumstances? And it's not just Botswana that's changing. It's global health as a field, right? It all started in the 50s, 60s with tropical medicine that has an awful legacy. With the end of colonialism, would move to international health, right? These were the years of the Almata Declaration, the big vaccination campaigns. And then with the end of Cold War, we moved into global health the way we know it now, which was triggered by HIV/AIDS pandemic. But over the past 10, 15 years, I think we're moving in a new era. And there's new challenges like the COVID-19 pandemic, climate change. So the field needs to evolve and BUP needs to evolve with the field. So presently, right, we have approximately 70 staff. There's 5 BUP faculty, myself included, who are here full-time, around 10 core operations staff, and then 55 project staff. Again, these figures are not carved in stone because as we get new grants, our staff increases. And then pre-COVID-19, we used to host around 100 visitors per year, a combination of Penn faculty and students, as well as faculty and students for other institutions and organizations. We're going back to that baseline, finally. It took 2 years. And, you know, we don't do HIV only anymore. These are all the areas of engagement. There's like lots of them. So very diverse portfolio, and it's a combination of research, training, health service delivery activities, as well as operational support. In terms of like the size of this enterprise, right? Again, our funding comes from sponsored programs. These could be like implementation grants from the Center for Disease Control or the President Emergency Plan for AIDS Release, or research grants from the NIH and Fogarty, as well as internal grants. We generate a little bit of income from the services like housing and transportation that we provide to the Penn faculty and trainees that come over. I should actually say Penn and CHOP faculty and trainees that come over. And then there's also like support from the institutions, primarily from the medical school, the health system, and also from CHOP. A picture is worth more than 1,000 words. So these are some pictures of projects and activities that we are currently pursuing. We have an oncology clinic at Princess Marina Hospital. Bottom left, again, we have residents from Penn and CHOP that come here and round at Princess Marina Hospital and work side by side with local residents. They're called Master in Medicine students, both for internal medicine, pediatrics, and other specialties as well. This is a picture of the Master of Science in Epidemiology students in trauma injury that are supported by Penn. CHOP has this wonderful global health fellowship that allows junior faculty to spend 3 years in Botswana, do clinical care, really become aware of the issues, and then develop a research portfolio that's really attuned to the priorities in the country. As I mentioned before, we have UB medical students that go to Philadelphia for clinical observerships, an outstanding operational team that really supports all the research training and health service delivery activities, Bottom left, those are the Master of Science in Epidemiology students in HIV, again, supported by Penn. We have a laboratory center at University of Botswana that we support, that it's a great platform also to train junior investigators from Botswana, and the community-oriented primary care projects in the Ngamiland district that Dr. Malebongo will talk extensively about. We celebrated 20 years, and we had a wonderful symposium about 6 months ago. This was in November, where all the Penn faculty and trainees, Penn CHOP faculty and trainees, and all our partners in Botswana had a chance to sort of talk about the milestones achieved over the past 20 years. And it was a wonderful celebration. The dean gave a wonderful speech. The Minister of Health of Botswana gave a wonderful speech, the US ambassador as well. But it was also an opportunity to look critically at the future and think, okay, what should we be doing going forward? What should the next 20 years, if we need to stick around for 20 years, of course, look like, or at least the next 5? And in answering that questions, we try to figure out, okay, what it is that we do differently. And we came up with a couple of answers. One thing is maybe like the way we partner. Of course, everybody values partnerships. It's not just us, but like trying to be like a little more like specific about what we value in partnerships. The idea that partnerships is not just a way to do things together, but it can really be a catalyst to transform the institutions and organizations that participate in them. And also that whatever project we take on, to really have maximum impact, the project cannot be self-contained, but needs to be a building block towards a higher purpose. So, and what does this mean? It means that if Penn or CHOP get together with University of Botswana through BUP, for example, to implement a research project, one measure of success is how well the project is executed, and if the knowledge that it generates helps change clinical practices and improve the health of people in Botswana. But the other one is how better off is University of Botswana going to be at the end of the project compared to where it started? And also how more capable to do global health are the institutions in Philadelphia going to be at the end of the project compared to where they started? And, in order to develop our strategy going forward, we felt like we also needed to come up with some sort of theoretical framework for health partnerships, for global health partnerships, because there really isn't like a lot of evidence base out there. It's gotten better over the past couple of years, but the literature is not super rich yet. So what we did, we brought together 7 global health experts. They needed to have more than 10 years of experience. They need to have managed at least a multi-million-dollar initiative, and work from a combination of high-income countries, low-middle-income countries. 2 of them were from Botswana, disclaimer. And they had worked across governments, NGOs, academic institutions, and donors. So there was like a diversity of experience. And we asked them 3 questions. What should be the key qualities and ideals of global health partnerships? What are the benefits of upholding these qualities? And what are the costs in terms of effectiveness of the partnership of not living up to these ideal and qualities? We sort of identified from the answers teams and sub-teams. We conceptualized them as qualities and pillars, and then we developed a theoretical framework. On this, really kudos to Fran Barg and Simon Schrigger, 2 qualitative researchers from Penn. Okay, they really like did all the hard work of the research, and we came up with this like framework where we divide partnerships in 3 levels. Okay, transactional, like really basic level. I scratch your back, you scratch mine type of thing, right? And when you have transactional partnerships that are purely transactional, the risk is that the organizational benefits trump the greater societal good, and specifically that the partner with more power benefits the most. The second level is collaborative, And the idea here is that there's more of a balance between organizational benefits and societal good, the greater societal good, and even that benefits are more equally distributed. And then the ultimate level, the one that we should all aspire to, it's easier said than done, is the transformational level. And here the idea is that the societal good, the greater societal good is more important than organizational benefits. And all partners in a transformational partnership need to be willing to step out of their comfort zone and do some things differently. And the partners who have the least amount of power should benefit the most of and faster. And this is a little different from what we're used to in global health, because I think traditionally this burden of changing practices, like doing things differently, which we've called capacity building, has fallen more on the partners with the least amount of power, whether it was underfunded Ministry of Health, understaffed health facilities, or marginalized community. And in a transformational partnership, the idea is that the burden of changing is really democratized and spread equitably across all partners. And what does it mean? It means that, again, every organization, institution that is part of a partnership must be willing to do things like differently, even in substantial ways. And these are just some examples. Like donors might consider funding more for longer with less strings attached, give money to national governments and local organizations rather than international players, avoid driving the agenda. Academic institutions may embrace social accountability. There's a bit of a movement for that, and consider rewarding impact as much as they reward academic productivity, or ensuring that academic productivity leads to actual impact in the real world. International NGO may accept to be willing, to be subprime on grants rather than the primary, and support local organizations. And national governments may increase funding devoted to health and maybe play more of an active role in coordinating all the development partners. And fundamentally, in a transformational partnership, every partner needs to constantly ask themselves this question: what can we do differently that will allow us to achieve a higher purpose? And a lot of these ideas, again, are not new. I think if you read papers, editorials about decolonizing global health, like these ideas are in there. And so going back to BUP, right? What we want to emphasize is that if organizations like the Ministry of Health, the University of Botswana, or Penn collaborate using BUP as a platform, that they will be able to advance their own strategic priorities. And of course, the circle around the institutions in Botswana is bigger because we are in Botswana, so their priorities should take precedence. And we developed a theory of change as well. And it works a little bit like this. So if you look at the left of the screen, right, you have University of Pennsylvania and a partner in Botswana. Let's say University of Botswana or the Minister of Health. Let's say that we partner together on a project, okay? If the partnership is rooted in these principles of equity, accountability, empathy, data, and evidence, the project is implemented well. That's the long gray arrow in the center. And one outcome will be that we will improve the health of people in Botswana. But again, as a result of the project and of working well together, the idea is that the partner in Botswana will strengthen its own capacity to implement a similar project on its own, or even scale it up, maybe even partnering with organizations that are not Penn. And Penn could do the same, right? Could be able to implement this project in other countries with other partners, and even back in the United States. And so we also changed our mission statement to sort of reflect this new emphasis on partnership. So the mission statement is improving health in Botswana and beyond through the power of partnership. And we came up with 5 strategic goals, because all these like ideals that I just mentioned are great, but how do we actually operationalize? How can, on a day-to-day basis or on a year-to-year basis, how can we go from the 50,000 feet view to the 10,000 feet view to the the 50-feet view. So we have these 5 goals, and the idea is that every project that's implemented through BUP need to be able to articulate how it will help advance these 5 goals. And I think they're pretty self-explanatory. I always joke that they're kind of saying like world peace, but I think they provide a good frame of reference to be systematic in the way we think about things, right? So the first is that we need to improve access, coverage, quality, and safety of health services delivered in Botswana, and ultimately improve health outcomes. 2 is that we need to strengthen the capacity in Botswana to sustain and scale these programs and projects. 3, we need to strengthen the capacity at Penn to sustain and scale these programs and projects. And I will explain a little more what we mean by that. 4, we need to generate and disseminate new knowledge. And 5, this is really, really important. We need to improve the effectiveness and the quality of the partnership. This is really the foundation of all the other goals. We need to work really, really well with our partners in country, because if we don't do that, we can't achieve the other goals. And what we did, we basically used the symposium where we had all these like presenters, both from Penn and CHOP and from partner organizations in Botswana, to organize working groups by area of engagement. And we ask each working group to articulate what their objectives would be over the next 3 to 5 years that are aligned to these goals. And, you know, some objectives were like, were more like specific, some a little more aspirational, because of course there's so much uncertainty with funding, for example. But I think it was a really, really great exercise, and we're in the process now of consolidating everything in a document that should become available shortly. And and you know, this is really the timeline for the strategic plan. Again, we started with the symposium. Then we identified key stakeholders both at Penn and CHOP and in Botswana by area of engagement. We established working groups. Then the working groups worked on objectives aligned to these goals for their area of engagement. And now we're consolidating everything in a master BUP strategic plan. And the idea is that we're going to use this plan year after year to sort of assess where we are and determine where we want to go, and maybe even change some objectives along the way if new priorities emerge. And, you know, going back to strengthening capacity at Penn as an objective, what do we mean by that? I think you can interpret it at 3 levels. One level is that, of course, this is a great platform for Penn and CHOP faculty and trainees to come and engage in global health activities. Okay. The second one is that, you know, maybe we can serve as a bit of a catalyst to establish systems to support faculty and trainees who want to have a career in global health, like, you know, establishing fellowships in global health. But 3, the idea is also on a more philosophical level that actually there are things that Botswana is doing, and a lot of countries in sub-Saharan Africa are doing in terms of improving patient outcomes and improving health equity that we could learn from in Philadelphia and in the United States. I don't think it comes as a surprise that many major academic medical centers in the United States, if you look at health metrics in the catchment area of these academic medical centers, you know, you look at life expectancy and you know, measures of universal health coverage, they're considerably lower than the average in the United States. So on par and sometimes lower than countries like Rwanda and Botswana. And if you look at HIV, it's actually really dramatic. This slide compares the outcomes for HIV in the city of Philadelphia. I think this was the report from 2020 by the Department of Public Health. So you have like 80% of patients that are linked to care, 45% of patients that are retained in care, taking ARVs, and only 50% of patients retained in care that have viral suppression. And you compare with what Botswana is doing. This is like preliminary data from a national survey, but it's consistent with like data from UNAIDS and PEPFAR, right? And you have 93% of patients aware of the status, 98% of patients on ARVs, and of those 98% of patients achieve viral suppression. And the paradox is that like people in the US, not just the PEN, get PEPFAR funding to go to countries like Botswana to teach them how to manage HIV or to work with them how to manage HIV. But there's like so much actually that they're doing right that we should take back home. Okay, so now we're actually going to zoom in on a couple of projects. So it's great to talk about all these big ideas, but how do like specific projects live up to these ideals and help pursue this goal? So we'll talk about two projects that are quite different. One is a big project. It's called the SHARE program. It's funded by the Center for Disease Control and Prevention, and it's approximately like $4 million over 5 years. One is a smaller project, but really, really meaningful, and we think has amazing potential. And Dr. Malebongo will talk about it, and we'll also talk about the strategy for primary healthcare that the Ministry of Health has. It's funded by a very generous private donor. We can't be grateful enough for the generosity of the donor, and it's around $50,000 over 2 years. So we thought it's just two great examples. So the SHARE program, SHARE stands for Surveillance of Healthcare Associated Infections and Antimicrobial Resistance, and it has three overarching goals. One is enhancing laboratory capacity to detect emerging antimicrobial resistance patterns, because actually antimicrobial resistance is a very big problem in sub-Saharan Africa and in Botswana, and it causes all sorts of nosocomial infections that have terrible outcomes. The second goal is strengthening the hospital epidemiology and stewardship programs. And the third goal is to deploy study teams to answer critical public health questions. So how are we going to do that? Well, the capacity of the laboratories is strengthened by establishing systems for antimicrobial sensitivity that are automated instead of manual. Those are much more accurate, and you can perform many more tests in much less time. And also creating biobanks, right? Where we sort of preserve the isolates and can perform like more advanced testing when the technology becomes available, like genome sequencing, for example. And then, of course, creating a data management system in the health facilities that we support, that is able to sort of process the data in real time and alert the different wards in the health facilities when there's an outbreak of a cluster alert, so that an intervention can be done to reduce colonization or reduce the incidence and the prevalence of healthcare associated infections with multi-drug resistant organisms. And then the third way in which we're going to achieve the grant's goal, again, is by using small teams that can answer critical public health questions. We're about to start actually a colonization feasibility study that is looking at when colonization occurs in newly hospitalized patients, if it occurs right away or after a few days, if it's more prevalent in one ward versus others, if there's like some risk factors in terms of like the patient, or other like ward-related factors that increases the risk of colonization. If colonization is associated with increased infections, and if preventing colonization will reduce infections. But again, so this is a project funded by the CDC, and they have all sorts of priorities that I of course, in part aligned with ours, but we still wanted to go through the exercise of taking this project and try to answer, okay, how is it aligned to the strategic goals of BUP? How are we going to improve, advanced goal 1, goal 2, goal 3, and goal 4 and goal 5, right? And these are the answers that we gave ourselves, right? Of course, by detecting and identifying, preventing, and containing infections with multi-drug resistant organisms, we're going to decrease morbidity and mortality in the health facilities that we support. We are strengthening the capacity of the labs in these facilities by providing equipment and supplies and reagents that they will take over. We're working with UB and MOH experts, and we're doing a lot of training and mentoring. Goal 3, of course, this is an opportunity for Penn experts to be engaged, and also CHOP experts. We're going to generate knowledge, but also, again, goal 5, really honing in on the effectiveness, the quality of the partnership. So making sure that whatever we do, there's joint planning with the partners at the Ministry of Health and University of Botswana, that we keep communication open, that we're accountable to one another, and that we align what we do also to national, local, and facility priorities. And how are we going to do that? Well, we have actually specific meetings, right? Starting from the bottom of the slide, we have our internal call-in meetings. We have collaborative meetings where we work with infection prevention and control stakeholders in the facility level, or even from other NGOs that work in Botswana. And then we have higher level meetings. These are really strategic meetings with the leadership of the Faculty of Medicine and Health Sciences at UB, and especially the leadership of the Ministry of Health and Wellness, including the leadership of the National Health Laboratory. And then the idea is that there's a path of sustainability, that whatever resources this program brings to the table, eventually, they will decrease over time, and the facilities will take over their management and will complement them with their own resources. And having said so, I think we can move on to Dr. Malebongo, who's going to talk about primary healthcare, the strategy of the ministry, and then the project in Maun. Dr. Malebongo, all yours.
Thank you very much, Dr. Corrado, and let me take this opportunity to thank the organizers of this webinar, and to thank all those that are in attendance. So my presentation right now, as already stated from the topic, will be to share with you as to the ministry's roadmap, and to try and align this roadmap with how it fits on with purposeful partnership and meaningful collaboration with the partners here in Botswana. Yes, the first thing that I want to share with you here is that core to effective partnership and transformational partnership is the ability of the country to have guiding documents that are leading or that are providing the stewardship on the delivery of healthcare services within that country. And this is just to share with you that indeed within Botswana, as we are working with the various partners, the Ministry of Health and the Ministry of Health is able to provide that stewardship through the documents or the policies that are already in existence and are in place, which then gives the partners a platform of where to draw in the priority areas. You will also see there within the Botswana Demographic Survey report, that is a very critical report in such a way that it provides I'll say regular updates on the social development of the population. And it is the very important report that we use to assess the impact of various partnerships that we have in Botswana. And I was including this one in particular since I'm talking about primary health that is important for social development. This slide is also to share with you to show, and I take it that this is not new to many of you. When we talk primary health, I would have started by describing primary health, but I take it that, or the assumption is that the primary health concept is quite known, and we have always used the easy definition of primary health will be from the cradle to the grave, being able to provide healthcare services or through an individual's life cohort, and being able to provide it within the environment to which that individual live. And this primary healthcare concept therefore talks to the system of providing healthcare services within a particular country. And this is just to show with you that while considering the provision of primary health care, and while having shown the guiding policies of the national guiding policies, we still subscribe to the international pillars for primary health that talks to leadership and governance, health service delivery, the human resource for health financing, and all the other ones. But important to us is the leadership and governance, community ownership, and partnership for health, and the research, and that is what is important. And we also zero in with the new emerging issues of primary health being equity, efficiency, and effectiveness to what we are doing, but more importantly in building the resilience of the healthcare system, knowing that what has been the translation of partnership before has been or was actually thought of as partners bringing in resources, and these resources, and hoping that they will continually be coming with the resources. But we know that the landscape have changed, and in changing, everybody wants to see a resilient healthcare system that is now able to drive itself, yet keeping to the quality of the healthcare service that individuals require. Here is just to show with you that one of the things that is guiding as I'm drawing into the principles of or the roadmap of primary health care in Botswana for the ministry is to show that what we put in the central of primary health is acknowledging that health is indeed a developmental agenda, and central to the provision or the provision and driving good quality health care outcomes is paying particular attention to the social determinants of health. And as you look in here, is to show that we cannot be talking about health in exclusion of talking about any other social determinants. And this talks to food security, talks to the education, the sanitation and water, and even issues of economy, that is the decent work and the responsible consumption and life on land and sea. And this are coming on into one health agenda. So now coming down to what the ministry is thinking about, and what I'm sharing with you here is in particular the roadmap for 2022-2023, for which the Ministry of Health and Wellness is prioritizing the revitalization of primary health care as a means of achieving universal health coverage. This comes from the lessons we have learned following the COVID-19 pandemic, which for many people have seen the disruption of the healthcare system as we know it. And we know now that the common theme that is emerging globally is building back better. And building back better means that we make the healthcare system that meets individuals' health needs through their lives, and ensuring that we build the resilience not only of the healthcare system, but the community resilience in order to be or adaptive to any other disruptions that may come through. So you will see it there in the red thing that here that we have prioritized it, and under that, the attributes being to meeting people's health needs through their lives, addressing the broader determinants of health through a multi-sectoral policy and action, and empowering individuals, families, and communities to take charge of their health. You will also see as you go down that we have not forgotten the partnership, and this is to ensuring that we engage our partners strategically and meaningfully towards a common goal of a healthy nation by 2023. So these are the core things, strategic things that are guiding us. I will, I think I must have skipped quite a few. Okay, here I am. Yes, and this is how we aim to do it as the Ministry of Health and Wellness, is that there are three key areas that we want to focus on. One being to improve patient experience in our healthcare services, that is to ensure that we deliver quality healthcare and there is active participation of the communities. Secondly, being to improve staff experience. Dr. Corrado was talking about building the capacity of individuals and their skills in order to continue providing what they do best. And this is also what the ministry is prioritizing: people management and appropriate resources and technology to ensure that services are delivered and the individuals, they have the right equipment to deliver the service that they need to. And the third one is to reduce cost of care, and this is to look into the efficiency in which we do things such that we ultimately have value for money. This is what I would say is what is causing the whole building back better and revitalizing primary health care. We already know what is broken as a country, and this is from both anecdotal data and observation. And what we have seen, or what we are actually responding to, is to see that we are seeing our tertiary centers are currently overflowing with clients, and they have tended to become the first contact of care. And this is what we know we do not want, and we know that this shows that the system at the bottom is broken. Our desire is to ultimately see a very mutually responsive system that at all levels, it is actually serving and providing the care that it's supposed to provide, such that there is retention of individuals at various levels of the health of the care system, yet receiving the quality of care that they need to enjoy, such that they continue to be of value within the economic chain. So this is what we really desire to see with the healthcare system that is responsive, reduce health expenditure, both at an individual and at an organizational level. And we see an equitable distribution of resources and outcome and a satisfied customer. And this is quickly more of a dashboard that we would like to see when we look at how we evaluate the outcome, such that we know and are able to stratify our communities appropriately. We see the community responsiveness, that is the community taking ownership. We see both the administrative and technical efficiency in how we deliver services. But importantly, what we have always been missing as a ministry is the middle square there, which is the social and economic, socio-economic and environmental determinants of health, which we have not otherwise been actively doing, which we are now bringing as a key component with this primary healthcare revitalization. And quickly to say that ultimately this is what we envision we will be seeing, where we should be seeing a synergistic or like an operative way in which both the public health data and the care data, that is the clinical data, are used collaboratively in order to inform any other services that we give at the community level. And this you can see where we are looking at household demographic and socioeconomic data, the environmental and public health risk data, and including the household disease burden. So what we have always been saying is that we prioritize the household disease burden, and this is shown by how we, most of our M&E systems, they are quick and responsive to clinical data and are able to talk about the disease burden, but we are not incorporating the public health information, which we now are bringing in as a very critical component to use while we stratify our communities and what they need. This is another very guiding document as I introduced the community program that we are now undertaking together with BUP. So the guiding document is the Integrated Community-Based Health Services. And this guiding document, it is to ensure that we standardize the way in which we have been approaching communities and we are giving services to the community. And the next slide here is to show that we are now introducing the community health workers program. And this community health workers program, how it is introduced in Botswana is that it's introduced in a 3-tier, where we have the community health worker 1 up to 3, and a community health worker 1 being a semi-trained individual who is able to take care of the community's health needs at a household level, while community health worker 3 is almost I'll say somebody who's at a volunteer level, and they however are able to do basic minimum data collection that is will be using to inform on the health needs of individuals and household at a lower level. Then we have a community health worker 2, who is almost a community surveillance officer, and this is an individual that will be situated at what we call the ward level or a cluster of household, and they are able to then keep a track on information that is collected from household level. So this is, I think this is a very common picture. It's a picture of how we have seen community health workers function in other countries. And this is what Botswana is aspiring to ultimately reach, where we have this individual who's able to reach certain communities and with basic healthcare needs or expand access to care. Now this is translating what we are doing, and this is to translate this which I was talking about at a strategic level, but now looking at it in a way that we are translating it into something that is actionable. So we have been working with UB and ourselves as the ministry through the DHMT to do this project, which is the community-oriented primary care in a small village that is within the Northwest, and the Northwest is within the Delta of Botswana. And through this project is just to have you appreciate, and I think looking at the time now, I'm just going to quickly go on how we have actually designed this project. The project is designed in a way that we are now going to be looking at collecting data that is comprehensive at a community level or at a household level. We use the data that is provided for at a clinic level, that is the clinical data, and we use this data collaboratively with the community to then formulate what is the local priority in order to effect change and effect good health outcomes. So this is just like I say, where you see now how we envision or how the community health workers work. And you'll see that at a household, we have a community health worker 3 who is collecting basic information. You have community health worker 3 at a class, community health worker 2 at a cluster level who is now collating this information such that it's available or readily available for use. And we have community health worker 1, who is then the custodian of anything else that happens within that community and is able to then liaise or link the community with the health facility that is available within there. And this is before then the data flows into the district health system up to the national level. And this is just a picture to show how we have worked with them. And I think if you are quick or your eyes are smart, you'll be able to pick Dr. Corrado there when he was at the meeting where we were doing the prioritization with the community elders. So we wish to share with you the data that, or the outcome of this data. And the reason we were sharing with you the outcome of the data is that we know that in many of these presentations, people are used to hearing about disease burden. But in here, we want to a little bit shift and show you that you can actually learn quite a lot by looking at or integrating the community demography, which is important to determine the public health risk. And when you look at the disease burden, then you can clearly see that the outcome of health cannot be talked to in exclusion to where the individual stays or the environment to which they continually live. And this is just to show that we, through this small project, which is a proof of concept, we have been able to map the environment of the people that live in these 2 villages to be able to draw a conclusion. And this is to draw a conclusion on the type of housing that they have, which we can see that though majority of the people have the modern housing, we still see some element of traditional housing. And you can see then importantly on the access to sanitary facilities, where we see that the majority of people did not have the sanitary facilities that meets the requirement. And many of them are then dependent on the communal level of water or water supply. and sanitary facilities. And this is important for us when we start thinking about issues of communicable diseases, including diarrheal outbreak. We also see in here the socioeconomic status and the energy supply, where we look at the environment to which they live, while majority of the people in these two villages are dependent on the, or they use firewood as a source of energy. And going on to see how the food security, that the majority of the people did not do much of the farming, therefore they are dependent on the food that they buy from the shops. And having said that as well, you will also see at the bottom there that despite being dependent so much on the food they buy from the shops, majority of the people do have a day in which they go without having what you call a healthy plate. That is a plate that will have fruit and vegetables, while some household actually go for a day without a meal a day. And we went on to look at the education level, where we'll see that majority of the people that we're talking to are not quite that educated, and also to look at the leadership of the household in here, where we have seen that many of the household are actually led from a female point of view, who are running these families alone, and they are children in this household. This information, as I'm talking to now, is still preliminary, but for the project and for primary health revitalization, this is a very important information in such a way that it is a basic of now planning on service delivery and how we will respond to these communities without being specifically biological in our approach of health delivery. So this is continuing on to showing on the employment level, where majority of the people have actually no income and are unemployed. Therefore, they are dependent on the social services. And that is the last one there, which is the Ipelecheng, or we call it the Ipelecheng. And here we looked at the health data, and in the health data here, we're just looking at the common communicable and non-communicable diseases, where we looked at the HIV status, and we have seen that HIV is quite predominant compared to the non-communicable disease, that is your COPD, your asthma, your diabetes, and even your hypertension. So this is now, like I say, we are continuing to collect this data and analyze it. And as I've said, it is preliminary, and we are looking on collecting more data to inform on the maternal and child health, both from community and health post. So this is, like I said, it's a proof of concept, and it's part of showing that there is value in using data both of public health and clinical care in a manner that then informs on the intervention. This is what we then are envisioning, that ultimately we should find I'll say a star area somewhere, where we are looking at the socioeconomic and health data from household surveys, we are looking at the health data from the facilities, and we're looking at the priority areas, and we should be able to then effect on, I'll say, come up with impacts or projects that are of impact at community level in order to effect change and to see or improve the health outcome. And this we give example, like one community is already thinking of community garden in Mazaudi to improve their nutritional status and reduce the malnutrition. This one is
Malebongo? Sorry
Yes.
to interrupt you. I just wanted to give you an update on time. We have about 7 minutes before the top of the hour.
We are done, and this is just, I think this one I'll just skip it in a way that it's a reassurance to say we have into it a monitoring framework and a path to sustainability and the scaling up, where we will be looking at the platform for training and research, and hoping to build a center of excellence in which people can learn on models of care from these proof of concept programs that we are doing. Thank you very much. That is the wonderful Okavango Delta.
There you go.
Thank you very much.
Yeah, no, thank you for that excellent presentation to both of you. So we're now open for questions. We have about 6 minutes or so. So feel free to type them either in the chat box or the Q&A box. And while we're waiting for those questions, I do have a question of my own. So this is a very, complex partnership, the BUP. It's longstanding, lots of intricate parts here at Penn, let alone others that, participate. So Corrado, just, from your time that you've been part of, director and part of the partnership, looking back, what would you say are some things that have worked and things that, necessarily haven't worked? If you could start all over and talk to your previous self.
I mean, I think what has worked is like the talent and commitment of like countless Penn and CHOP faculty and trainees who over the years have come here and done amazing work. And what has worked is like, the talent of our partners in Botswana and how committed we've been to the partnership long before I came. Again, like really, like there's so much credit that needs to be given to like folks that have been working here for 20 years. What is challenging is the system of incentives, to be honest. Like we're kind of like stuck. Yeah. And primary healthcare is a perfect example. It's so important. Like there's all these communities out there in the Delta and like in the Kalahari Desert, like all over Botswana, all over sub-Saharan Africa, that needs solid primary healthcare. And also, it's a wonderful opportunity like to do meaningful research in primary healthcare, to train primary healthcare practitioners, to foster collaboration across sectors. There's no money for it. Like there's just no grants for primary healthcare. It's just so infuriating. Like, sorry.
No, I think you're in good company. A lot of people would agree that have joined here about that.
So that's my short answer.
Okay. And let's see. There's no other. Oh, there is a question here. So could you comment on how best to attempt to replicate good outcomes and avoid pitfalls related to partnerships between Penn and Botswana and other regions of Africa, Latin America?
Okay, I guess it's
yeah, it wasn't. It was the
partnerships in general.
Yeah.
Yes. Thank you very much for the question. I think one of the things that I can also always say is that one thing about partnership is to ensure that there's mutual respect between the two entities. That is the partner and the recipient for that or whatever help that is coming through. And for also to ensure that when we look at partnership, we should be looking at ministries of health, or because I'm coming from a Ministry of Health, I'm coming from a government point of view. We should always be looking at capacitating governments and ministries of health in order to take a true lead and true stewardship. And this can only be translated if they have guiding documents, because that way it means that whatever that is coming through, it is not haphazard, it is within a bigger, broader perspective of delivering healthcare services or delivering service as they want it. And they can also be a shared vision and shared focus on the entity that they want to deliver. So that way, then you don't have where partners are then competing and there is so much inefficiency and duplicity and silo operation mentality within one area. I'll say that is very important, or that is what as Botswana we have learned, that remaining in the level of control in stewardship and having very versatile documentation has helped us to be able to tap on various partners and focus them towards a common achievement. Thank you.
There's a follow-up question. Are you aware of such documents for guidance in West Africa, such as Liberia?
Documents.
I think in general, I wouldn't be aware of the documents in Liberia, but in general, like I was looking at the document, I was giving presentation on the documents for Botswana. In general, in here, I'm talking about having a clear national health policy. If you have a clear national health policy, it means assumption is that, articulated in there is the national vision, is the national mission, and is the resources of getting towards that mission and vision. If you have like an essential health package, you have already articulated what is it that you want to give the communities and how are you going to give the communities. So those are the things that we should be looking into, or for any country, that at bare minimum, are the policies that are guiding on the delivery of healthcare services? Thank you.
And on that note, in terms of like referring to these like strategic documents that the ministry produces, of course, it's incumbent on us as partners to familiarize ourselves with this, but also like the process of aligning ourselves to these documents and try through our projects to advance these strategies. That's an active choice, because if you follow the system of incentives, like the risk is always that you get tunnel vision with your own project, because it's just because that's how the system is set up. Whereas really like how can this project become a building block towards like this greater vision? How can I make the money that sometimes is very vertical, very stifling and restrictive, how can I make even that money work for the bigger picture? Yeah, and that's an active effort.
Okay, thank you very much, Corrado. So we have a question here that's asking about how did the collaboration between the University of Botswana and UPenn start?
Yeah, I mean, that's long before me, and again, all the credit in the world to Professor Harvey Friedman. So he can probably he will be able to speak much more eloquently about it. It was really like the main driver was the HIV pandemic. Because there was such a dire need to start people on treatment, and then all of a sudden, right, like all this money became available, right, through the Global Fund and PEPFAR. That was really like such a unique, a special moment in global health. We haven't had one since. I was hoping like 8 years ago that Ebola could serve, could serve as a catalyst and bring another $15 billion a year. I was hoping COVID would do it, but we haven't seen any of that. Like there hasn't been a moment like that in global health history, where there's all of a sudden all these resources to meaningful work. So
thank you. Thank you. Yeah.
Hopefully it doesn't take another disaster though to get there. Yeah.
Absolutely. We do have one last question. I know we're a bit over time, so if you could answer this the best you can shortly. Could you comment on how do you think cancer care fits in the general scope of healthcare in low-middle income countries?
How do we think cancer fits in the
into the general scope of healthcare in low and middle income countries, like when they're developing, their strategic plans, like how does something like cancer fit into that?
I will talk from the point of Botswana. Right now, we are in the process of developing the National Cancer Control Plan, and this is rooted through the primary healthcare model or approach of delivering healthcare services. One of the things that we have learned as a country is that cancer, if you leave it to tertiary level, it becomes very expensive to manage, to treat. It's even expensive to the individual because of the lives lost. So in order to change that, we have more kind of systematized cancer, such that we started by effecting even the lifestyle modification through your regular non-communicable disease risk factor response, and that is looking at individuals' modifiable risk factors such as your drinking, use of alcohol, smoking, healthy food, exercise, and obesity, and that is in a bigger framework of non-communicable disease control. Then we have the next level, which is both the primary way for screening And the screening, we have the screenable cancers, that is your cervical cancer, that we do the screening, and it is systematic, and we have the plan or the strategy for delivering that screening. And we then go down to treatment and care, including palliative care, which we do at the community level, and the rehabilitation. And this is to ensure that individuals are continually, we do the pain management at community level. So I would say that just like or aligned to the WHO call, cancer should be infused, or cancer management at the low and middle income countries should be infused within your overall primary health care approach of doing things, in a way that you are able to catch it early, you are able to then take the critical preventative measures at community level, and you are able to give transformational care, especially when it comes to pain management, when it comes to palliative care, which we usually fail on, and you are able to take it at a community level. So that would be my view. Thank you.
Thank you very much for your comment and answer. And with that, I don't see any other questions, and I want to be respectful of everyone's time, and just thank you both for taking the time to speak with us and answering our audience's questions. This presentation, as well as others within the seminar series, can be found on the Center for Global Health's YouTube page. Feel free to send us any questions. And if we have any questions afterwards, I'm sure these two would, answer them. We can connect you with them. Are there any last words from either of you?
No, I mean, for me, just thank you so much for organizing this, Alejo, and thank you so much to the attendees. It was our pleasure.
Thank you very much, Alejo, for this wonderful opportunity. And I look forward, it's my first time and I've enjoyed it very much. I look forward to more presentations. Thank you.
Yeah, thank you again. And everybody have a great rest of your day. Thank you. Bye-bye.